Thank you. Welcome to my session. Thank you, Ganesh Kendra and Professor Mahmood Mustafi sir, to give me chance to speak something. And with the permission of our respected chairperson and others, thank you. My today's topic is management of refractory lupus nephritis. Up to 60% of adult patients with SLE developed renal disease differing in severity during the course of illness, despite of the introduction of corticosteroid and other immunosuppressive agents, which have profoundly changed the management of lupus nephritis. But between 20 to 70% of the patients with lupus nephritis reported to refracted to standard immunosuppressive therapy. Novel alternative therapies are currently available, include multi-target therapy and various biologics that target B cell, T cell, and cytokines. The European League Against Rheumatism, EULAR, and ERA and EDTA recommendation the term refractory lupus nephritis in reference to adherent patients who fail to achieve either complete or partial response to the initial standard immunosuppressive therapy or whose renal function deteriorates on therapy with 6 to 12 month period. The guideline of American College of Rheumatology defined refractory lupus nephritis and worsening nephritis by 3 months or treatment failure as assessed by the treatment physician by 6 months. There are several problems. Why we focus on proteinuria and creatinine? There are several problems with the focus on declining proteinuria and creatinine as a marker of remission. First, emerging data on protocol rapid biopsy performed after complete clinical remission shows continuing histologic activity in a significant number of patients. Secondly, there are other non-immunologic mechanisms of renal injury which may lead to changes in creatine and protein, including thrombotic microangiopathy and secondary focal glomerulosclerosis. The role of renal biopsy. The renal biopsy should be considered for patients on induction therapy presenting with worsening proteinuria and creatinine. Whilst immune complex mediated lupus nephritis is the most common cause of kidney disease in SLE, other mechanisms can result in renal injury. Example, thrombotic microangiopathy and antiphospholipid antibody-induced vascularization. Emerging data that serial biopsy may inform ongoing treatment decision. After completing 6 to 8 months of immunosuppressive therapy, 30 to 50% of the patient complete clinical responder will still have histologic evidence of active lupus nephritis, and 40 to 60% with no histologic evidence of the disease activity still have had persistent high-grade proteinuria. The importance of achieving complete or partial response was illustrated by the lupus nephritis collaborative study group. Patient who achieved complete remission, 10-year patient survival and renal survival, and this graph shows renal survival and patient survival, complete response 95%, and patient survival 94%, and partial responder 76%, and renal survival only 45%. And in case of non-responder, it is only 46% and only 13% for renal survival. Thus, even partial response is better than no response in patient with proliferative lupus nephritis. Our therapeutic approach should be criteria for complete or partial remission not meet the after 6 to 12 months of period of induction therapy, assess adherence to therapy, and review the prescribed therapy that follow the guideline and dose. Rapid renal biopsy to exclude the other renal lesion. Our term refractory lupus nephritis, then we switch from MMF or cyclophosphamide and vice versa. And we also consider rituximab as an additional alternative therapy, combined multi-drug therapy, and prolonged course of IV cyclophosphamide. Our first approach, switching another first-line induction agent, is recommended initial approach of patient with lupus nephritis as is recommended by EULAR and ERA and EDTA and American College of Guideline. In general, cyclophosphamide-resistant patient treated with MMF or MMF-resistant patient treated with cyclophosphamide. In addition to switching immunosuppressive agent, some accompany with 3 days IV corticosteroid. And this graph shows patient receiving MMF after cyclophosphamide resistance, and in 3 months, new patient complete new responders 38%, and in case of percentage complete remission 14.1 and 35.5 in partial responder. And our next course is extended therapy for cyclophosphamide can be considered for patients who fail to meet the remission criteria by 6 months. A Chinese study, patient with lupus nephritis cumulative doses determine the initial treatment approach. However, significant toxicity of cyclophosphamide such as infertility, urotoxicity, and oncogenicity, which are particularly relevant as most patients of childbearing age, is a major limitation. Ovarian reserves is inversely related to cumulative dose of cyclophosphamide received, and concomitant use of gonadotropin releasing hormone analog should be considered. Our next target, B cell therapy. B cell play the principal role in pathogenesis of lupus nephritis, and they are an attractive therapeutic target. Several uncontrolled studies reported the efficacy of rituximab in patients with refractory lupus nephritis. However, two trials, Explorer trial and Lunar trial, both of these trials failed to demonstrate any significant therapeutic efficacy. Despite the failure of Lunar trial to meet the primary endpoint, advocacy of use of rituximab in refractory lupus nephritis continues and is primarily based on observational evidence, especially in patients who have an inadequate response to first-line induction agent. In a systemic review published case report and case series on the efficacy of rituximab in patients with refractory lupus nephritis, 300 patients who are followed up to 60 weeks and have sustained complete partial response rate 87, 76, 67, and 76 patients with class 3, 4, and 5 and mixed type. And this graph shows overall partial response 35% and full responder 40%, and in case of class 3, 60% and partial response 27%. And in case of class 4, 45% complete response, partial 31%. And in case of mixed type, it is partial response 52, complete 24%, and non-responder 24%. And now calcineurin inhibitor. Calcineurin inhibitor, cyclosporin and tacrolimus have been studied extensively in lupus nephritis, especially in Asia, with emerging evidence for the efficacy of refractory lupus nephritis. The CNI shows encouraging result in open label trial and potential toxic alternative to conventional therapy. And this graph shows patient using CNI, their activity score is reduced and steroid dose is also reduced and markedly reduced proteinuria, but no difference in serum creatinine. And now multi-target therapy. Multi-target therapy comprises of steroid, tacrolimus, and MMF has been investigated in a prospective randomized control level trial for induction treatment of lupus nephritis and has been shown to be superior to IV cyclophosphamide induction therapy in 6-month remission. This graph shows multi-target therapy which is superior to IV cyclophosphamide. Plasma access and immune absorption. A randomized control trial conducted by Lupus Nephritis Collaborative Study group examining the efficacy of plasma exchange when added to standard therapy in patients with lupus nephritis failed to show improvement in clinical outcome. In a study of 8 patients with refractory disease who underwent immune absorption had concomitant cyclophosphamide, all patients had reduction in creatine and urinary protein excretion. Extracorporeal therapy is sometimes been considered for patients with contraindication to standard therapy, including severe infection risks and significant leukopenia, as well as other indications such as pulmonary hemorrhage. Our next therapy is belimumab, which is recently used. A pooled post-hoc analysis, the BLISS trial, evaluated 267% who had activated renal involvement at baseline. A trend toward the reduction in rate of renal flare and level of proteinuria, as well as increased rate of renal remission were observed in belimumab group over 52 weeks. Efficacy of belimumab is more pronounced in patients with receiving MMF or those are serologically active at baseline. And this figure shows patient using belimumab 10 mg per kg, renal flare is decreased only 1.4 and while placebo 3, and in case of patient renal remission is 70.5 and placebo 30.8. 58.7, and this figure shows patient receiving belimumab is more efficacious than other drugs. Other biologics, 2 randomized control trials were recently published comparing the co-stimulation blockage with abatacept against standard care of active lupus nephritis. The ACCESS trial found no difference rate in complete renal response at 6 months when abatacept or placebo added to low-dose cyclophosphamide. In a recent study, 298 patients randomized abatacept on placebo, both administered on the background of immune suppression with MMF 2 to 3 mg per day and oral prednisolone. After 12 months, abatacept failed to increase rate of complete renal response over placebo, although greater reduction in proteinuria was observed abatacept treated patient with nephrotic syndrome at baseline. There are new recent trial is ongoing. A number of novel trials are currently in pipeline for the assessment of lupus nephritis, including interleukin-6 blockage. And these are the recent trial ongoing. Voclosporin, which is a calcineurin inhibitor, obinutuzumab, and belimumab and belimumab and rituximab. These are phase 3 and phase trial ongoing. And our therapeutic approach should be lupus nephritis not responding to initial therapy, rule out the causes of other cause of renal failure, drug side effect, dehydration and perirenal azotemia, obstructive nephropathy, and use of radiocontrast. Then switch from cyclophosphamide to MMF, and no response, then patient with persistent proteinuria more than 1 gram per 24 hours, and consider combination of microphat mobile and calcineurin inhibitor. If no response, then rapid biopsy, or if GFR deterioration, then also renal biopsy. If renal biopsy shows class switching, active inflammation, minimal or moderate chronicity, then rituximab or multi-target therapy or immune absorption. If renal biopsy shows advanced chronicity and minimal activation, then no intensification of steroid, consider gradual tapering after 2 years, and monitoring and treatment of chronic renal insufficiency and other comorbidities. Maintenance therapy. Very scanty data are available regarding the therapeutic option for maintenance of renal response in refractory lupus nephritis. The choice largely depends on physician experience, but also on the agent used to induction response. In this regard, if MMF is used for induction and lead to renal response, it seems to be reasonable to continue through the maintenance phase. The efficacy of MMF after cyclophosphamide, nearly 16% patients relapsed after discontinuing MMF. If cyclophosphamide is used for induction, prolonged IV cyclophosphamide, prolonged IV pulse can be used consolidation to response. The pivotal
already 12 minute cross kore geche.
Okay, thank you. Last slide my. The pivotal initial study, National Institute of Health, shown that prolonged IV cyclophosphamide pulse associated with beneficial renal outcome is very long terms and with acceptable profile data, and there is no study nor specific target the patient with refractory lupus nephritis. And in summary, lupus nephritis that are refractory to first line induction therapy is associated with worse renal and patient outcome. Thank you for patient sharing.